Okay, so we have finally gotten to the last lecture of the quarter. Pretty exciting, right? So we're just going to talk about traumatic brain injury and stroke. We definitely talked about stroke in the last chapter, in chapter 19, which is one of the reasons why I brought it forward from 17 and 18 so we could discuss the details about stroke. And now we're just going to talk a little bit about the effects of stroke and stroke rehabilitation, and then we'll also hit on traumatic brain injuries, including concussions, which are considered to be mild traumatic brain injuries. I meant to include this information about lateral pulsion in the last PowerPoint, but I didn't. And its lateral pulsion affects approximately 10% of people post-stroke. It is also sometimes called pusher syndrome or controversive pushing, where the person pushes away from the less affected side in sitting, as well as during transfer, standing, and walking. So they're pushing towards their weak side. They extend their less affected arm and leg, and they push, and it creates a high risk for falls. It's dangerous for them, and it's dangerous for their caregivers and therapists who are helping them. Within the first week post-stroke, about 63% of people demonstrate lateral pulsion, but only a smaller percentage, 21%, persist in pushing at 3 months. And at 6 months, it's usually resolved. But the reason that we address it is because it is a risk. It's definitely a high fall risk, and it's really difficult to break someone out of that passively. So they're extremely resistant to adjust their posture passively into a symmetrical position. Next quarter in neurorehab, you will talk about some treatment strategies for lateral pulsion. The proposed mechanism of it seems to be a deficit in sensing postural alignment relative to gravity, and it's a lesion of the posterior thalamus. So it's the reason I wanted to include it in the last PowerPoint is because it's closely related to spatial neglect. It's like a gravity neglect. You could almost think of it like that. So it's definitely can be difficult to treat. However, with 6 months after stroke, a large number of people this has resolved. So it's in that first 6 months that you have to worry about it. So with traumatic brain injury, we're going to divide it into two different categories, sort of. Mild to moderate, or moderate to severe. So a mild to moderate brain injury is a concussion. And I think probably a lot of us who either played contact sports as kids or were avid bike rider, tree climber, creek jumper type kids experienced this as kids. I think when I was a kid, I was on a first name basis with people in the emergency room. And so I had a few of these mild traumatic brain injuries, concussions. And usually a single concussion causes no long-term cognitive abnormalities. So usually a concussion is distinguished by a brief loss of consciousness, possibly transitory post-traumatic amnesia, or a brief period of confusion following head trauma. About 15% of people following a concussion develop post-concussion syndrome, which is a lingering set of disorders that most frequently include poor cognitive function, difficulty with concentration, and irritability. The more concussions you have, the more chance you have of developing post-concussive syndrome. So luckily, there has been good recognition in the medical and sports community of the danger of cumulative head trauma in kids playing contact sports. And more schools are educating coaches, athletic trainers, parents, and athletes about the seriousness of concussion. So a lot of times, and it happens when you're in sports, I'm sure that a lot of us have experienced it, where you get your bell rung, you take a hit somehow and you feel dizzy, and a lot of times young athletes particularly will sort of brush it off and say, oh, I'm okay, they don't want to be taken out of the game, they don't want to lose any playing time, and the consequences can be that they don't get the treatment that they need, they're not they don't get the rest that they need to recover, and then they have longer term effects. So a lot of communities and between the medical and the school community are starting to form concussion task forces to help address this problem, and I think that's a fantastic thing, because if it's recognized and treated, someone has a much less chance of developing post-concussive syndrome and developing problems because of it. When it comes to major or moderate to severe traumatic brain injury, most of them occur in motor vehicle accidents. Impact in a motor vehicle accident tends to damage the orbitofrontal, anterior, and inferior temporal regions and cause diffuse axonal injury. So just like with strokes, the effects of a traumatic brain injury are influenced by what areas are damaged. So in infants, often traumatic brain injuries are attributable to accidental falls, but brain damage after most falls by an infant are relatively minor, because the baby is small enough that they just don't have the force behind them with their weight to cause major damage. So most severe brain injury in infants requires greater force than a typical fall, and usually it's caused by when an infant is violently shaken, or that shaken infant syndrome. The trauma of shaking is due to the impact of the brain striking the skull repeatedly. So that's where most traumatic brain injuries in babies come from. So in the book and in the module, there is this pathology book. In the book, it's on page 445, pathology box, that talks about traumatic brain injury. It's diffuse axonal injury, and can include contusion, hemorrhage, swelling, and or laceration of the brain tissues. It's caused by trauma. In its name, traumatic brain injury. It's acute onset because you have an accident, something happens. The signs and symptoms can be widespread depending on which areas of the brain are affected. So the personality effects can include decreased goal-directed behavior, impulsiveness and other inappropriate behaviors, low tolerance for frustration, emotional lability, and delusions. So that depending, again, on which area is affected, those things can all happen. Cognitive effects can include slow mental processing and decreased cognitive flexibility. It largely does not usually have an effect on anybody's intellect, but that slow mental processing and changes in personality and impulsiveness can really change someone. Consciousness may be impaired temporarily or sometimes for a prolonged period. But even after consciousness is regained, someone with a TBI often has difficulty directing attention. They're highly distractible, and they also have difficulty attending to several things simultaneously. So communication is usually normal, and declarative memory impairments may be temporary or they may be prolonged. So that, again, is going to depend on what parts of the brain are affected. You might have sensory impairments. You might have some autonomic impairments, and motor, again, depends on the severity of the injury. But motor impairments can include paresis or paralysis, spasticity, contractures, issues with balance and posture and gait, speech issues, and swallowing or eye movement disorders. So all of those things can be affected with a traumatic brain injury. So in motor vehicle accidents, the most frequently affected areas are anterior frontal, ventral frontal, and temporal lobes because of the way auto accidents happen. So I have found working with people with brain injuries in therapy, whether it's a new brain injury, you're working in an acute rehab setting, or something like that, or whether it's an old brain injury and you're working with them in therapy on something else. People with brain injured people can be very difficult to work with because of their low tolerance for frustration and impulsiveness, and often the inability to distinguish whether their behavior is appropriate or not. So their intellect and communication may not be affected, but all those other things are making it very difficult. So there's one woman that I worked with a few years ago. We were working on a different injury. We were working on a hip fracture, rehabbing from that, from a fall. And she had had a brain injury from a car accident years before. She was very intelligent, very knowledgeable. She had a lot of knowledge of anatomy and physiology. However, her goal-directed behavior and her impulsiveness and failure to be able to distinguish what is appropriate and what is not would often lead her to do inappropriate exercises for her particular orthopedic issue. She did catch on to things quickly, but she didn't always make good decisions. So a lot of times traumatic brain injuries can seriously change someone's life. It can make it, even though they still have good mobility and some other things, it can make it difficult to maintain relationships and keep jobs because of those behavioral and personality changes. And so a traumatic brain injury can change someone's life drastically. I worked with another young man who was in a motorcycle accident. He had a lot of the motor and sensory impairments as well as some of the other impairments. He was a really hard worker and he really wanted to get better, and that helped a lot. He also had really super good family support, and that really helped a lot too. I did a lot of aquatic therapy with him, and I love aquatic therapy for neurological patients because it gives you so much sensory input when you're in the water. So people who have sensory impairments, they might not have good conscious proprioception or be able to tell where their limbs are in space. But in the water, they're getting all that extra sensory input, and it makes it easier for them. So even people that have really big motor effects, such as paresis, spasticity, contractures, etc., the water is a really good environment for them to work as well because they can move more easily in the water. The buoyancy gives you that ease of movement, and you can do a lot with people. So I've worked with a lot of stroke patients and TBI patients in the pool, and I think that's a fantastic area to do neurological rehab. So in the module there are a couple short videos. One's 8.5 minutes long, one is 4.5 minutes long. Optional, of course, but interesting. The first one is on the effects of TBI, and the second one is on concussion or mild TBI. So very interesting areas to work in. I'm really glad to see the progress made in the medical and sports communities on addressing concussions and the possible repercussions from that. So we're going to go on to talk about stroke, and we did already talk about it in the last chapter, in chapter 19, but we're just going to talk a little bit about the signs and symptoms and the rehabilitation of strokes. So again, a stroke or cerebrovascular accident, CVA, is the neurologic outcome of an interruption of blood flow to the cerebrum, depending on the cause, location, and size of the infarct or hemorrhage. So infarcts occur when an embolus or thrombus lodges in a vessel obstructing blood flow. That's an ischemic stroke. Depending on the location and the size of the lesion, a small insult to the cortex can produce no symptoms, whereas a same size or smaller lesion in the brainstem could cause death, because the brainstem controls a lot of vital functions. So a smaller, in the cerebral cortex, other areas can functionally take over for the missing area if it's not very big. We talked about that a little bit in the neuroplasticity chapter in chapter 4. So if you have just a small area affected, other areas can take up the slack on those functions. But in the brainstem, you don't have that flexibility, and if you have a lesion in the brainstem, that could be the end of it. So large hemorrhages or edema. Edema is secondary to large infarcts, can cause death regardless of location because it can compress those vital structures. So hemorrhagic strokes have a higher incidence of causing death than ischemic strokes do. So a lot of times we'll talk about hemiplegia and hemisensory deficits as being unilateral. We'll say the uninvolved side. It's actually probably more correct to say the less involved side, because as we've talked about a lot of the different functions, some of them cross over, some of them do not. And so there are going to be effects on either side. But one side will be involved in a different way from maybe the hemiparetic side or the hemisensory side. So a lot of times we'll say the uninvolved side, but it's really the less involved side. So in terms of effects, large hemorrhages can often have effects similar to traumatic brain injuries because so much of the brain is affected. So one of my recent patients that I've been working with actually started out with a traumatic brain injury. He fell at work and hit his head on the corner of a desk and had a traumatic brain injury. So when he was, they took him to the emergency room. He certainly had some edema and a little bit of hemorrhaging, but it wasn't extreme, and he had some hydrocephalus starting, but it wasn't detected when he first went to the emergency room. So he went home, and things continued to bleed. He continued to have some hydrocephalus because he had subarachnoid bleeding, and the pressure was building up in his brain, and he ended up having a stroke. Because the pressure builds up in the vessels, he had a hemorrhagic stroke. Again, was in the hospital for that. And then ended up with hydrocephalus, had to have a shunt put in. He had some shunt dysfunction, so this guy really had everything that could go wrong, went wrong. And now we're a year out, and we're working on gait and balance and regaining his sensory and movement deficits. And he's a great guy, great attitude, super good family support, which is so important in recovery. And all that stuff happened in the course of a couple months, and now a year later he's working hard on the recovery from that. So even though most of his stroke effects were on the right side, so they'll say right CVA, left hemi, he definitely has effects on his right side as well. So his course of injury and treatment was definitely more complicated than a lot of people's, but he is working hard and having some good recovery. And so no matter what the extent of the damage, we can always work with people and try to improve their quality of life, improve their movement, improve their mobility, and increase their independence. I mean, that's hugely important. He's probably never going to get back to where he was a year ago before the accident, but he's going to be as good as he can be. And he's dedicated to working towards that, which is really great. So when we're doing stroke rehabilitation, there are lots of different approaches that you can take. Compensation approaches emphasize performing tasks using either the paretic limb with an adapted approach or using the non-paretic limb to perform the task. So with the guy I was just talking about, we use some of this compensation approach. He uses an AFO on his paretic side, which is his left side. So that AFO helps lift the foot up into dorsiflexion when walking. So it's not the muscles doing it. We're not working on motor control of those, we're using a device to adapt and make it possible for him to do it. And then on his non-paretic limb, he uses a hemi walker to help perform the task. So that's the compensation approach. Remediation approaches attempt to decrease the severity of the neurologic deficits. So again, in that same patient's case, one of the remediation approaches was the shunt to decrease the amount of hydrocephalus. Usually remediation approaches are medical or surgical. A medical remediation approach might be the injection of Botox in an area with a lot of spasticity. A lot of people with CVAs or CP will get Botox injections in the area that's most affected by spasticity, and it can be really helpful for improving their movement. Motor control approaches emphasize task specificity, so practicing the desired task in a specific context. So you're trying to regain motor control. And with that same patient, we're also doing motor control tasks. We're working on balance. We're working on advancing the left leg, and engaging the right muscles in order to do that. I was working with another patient last year who was a fairly young woman. She had the stroke while she was in labor for her first child. So she has a 1-year-old baby now. And a lot of the things that we work on are task specificity. Again, she will come in with a list of, here's what I had trouble with, this, and this. Here's what I want to work on, this, and this. So practicing the desired task in a specific context. A lot of her things that she wants to work on have to do with caring for her daughter. And it's really important to her that she doesn't appear disabled to her daughter. She wants her daughter to grow up thinking of her as normal. So she has great family support. Her husband's really supportive, and she works really hard. So the approach you take, a lot of time, it's going to depend on what is going to benefit the patient most. And most times it is a combined approach. Use compensation, use remediation, and use motor control, because you're trying to get the best outcome for the patient that you possibly can. So the last assignment in this module, the last assignment of the quarter really, besides the exam 3 and your winter quarter project, if you haven't turned that in yet. Some people have already turned it in, so they're really close to seeing the light at the end of the tunnel there. But the project that we're going to do this week, or the assignment, hopefully it'll be fun. I think by the end of the quarter we all sort of need a fun assignment just to get us through to the end. There are 2 PDFs that I want you to download. There are line drawings. You're going to do this with another person. You're going to recruit a friend or family member. And you're going to describe to them how to draw something. They're going to try to draw it without looking at the picture. And we're just then we're going to have a little discussion about the communication difficulties that might make that task hard. So kind of a fun project, hopefully no pressure on that. And we all need that at the end of the quarter. I will definitely be having a chat review towards the end of the week, probably on Thursday, the 15th. And then we will have that last exam. And if you haven't already turned in your winter project, you have a few days to polish that off and turn it in, and then you'll be done for the quarter. So I think it's been a fun quarter, and I hope you've all learned a lot.